Welcome. My name is Jody Craner. I work with the Wisconsin Alzheimer's Institute at UW-Madison. Today's webinar is Screening for Dementia in Persons Living with an Intellectual Developmental Disability. My co-presenter is Amy Pope, who is a licensed professional counselor and behavioral health supervisor at Community Care. Amy, do you want to do a little bit of an introduction of yourself?
Sure. Hi, I'm Amy Pope. I'm one of the behavioral health supervisors with Community Care, which is a managed care organization that functions in the state of Wisconsin. A little bit of background about myself. Gosh, I'm going to age myself. I've been in the field, started in residential, back in probably 1997. So that probably really ages me. Probably back in 2004, I got into case management, working for various county entities. And then back in 2010, when a lot of those programs switched over into family care, I started working with Community Care. So I've been with Community Care since 2010, started out in case management, and then moved into the behavioral health specialist role. So yeah, I've been working, and then later, probably last year sometime, I moved into functioning as one of the behavioral health supervisors. So yeah, my background, I have LBC. I'm a licensed professional counselor. My master's is in psychology. And yeah, so that's a little bit about myself.
Thank you, Amy. Appreciate that. For those on the webinar, if you want to put comments and questions in the chat, when we're done with the slides, we will turn off the recording and then have an open discussion about those. So again, welcome everyone. So today, the goal is to identify the challenges in detecting dementia for those living with an intellectual developmental disability, or IDD. Provide an overview of the National Task Group's Early Detection Screen for Dementia tool, otherwise known as NTG-EDSD, or sometimes just abbreviated EDSD. And then to hopefully increase your knowledge on how to and when to complete this tool. And then we're going to discuss Community Care's incorporated experience utilizing the tool. They've embedded it fairly smoothly into their entire system. And then we're going to talk a little bit about the benefits and the drawback of the tool. So just to get a sense of what my perspectives are of the aging brain in terms of what can happen, I view it, there are 4 scenarios that can happen as someone ages. The first is this green line, that is when someone goes through their entire lifespan, and then at the time of their death, they really haven't experienced any significant cognitive changes, no impact on their life. And so this is age-associated or normal aging. And the great news is there are a lot of folks that actually do live their entire lifespan without any major cognitive changes and only have these age-associated ones. The second scenario in middle adulthood that can evolve with the aging brain is mild cognitive impairment, or MCI. This is where the person has changes going on in the brain in one or more domains. And when they go in for formal evaluation, some of these changes are subtly picked up on testing. However, it's not sufficient enough to actually impact the person's ability to do everyday life. The third scenario is this purple line, dementia. This is where someone has cognitive changes going on in their brain, one or more domains. And these changes are significant enough that they're impacting the person's ability to do everyday life. And so this would be formally dementia. The fourth scenario for middle adulthood is when someone is living with MCI, mild cognitive impairment, and changes continue or resume, and then the person converts actually into dementia condition. So when we look at this, and our focus is going to be looking at that aging brain for someone who's got IDD. And just to make sure that we're all talking about the same folks within the developmental disability larger group, when you look at that, someone can have a developmental disability. It could be intellectual in nature, physical in nature, or both intellectual and physical. The subset of people we're talking about are the folks that live in have an intellectual disability. And so let me give you an example of someone who would not be who we're talking about today. So when I worked as an executive in Milwaukee County for a large nonprofit, I had an accounting partner who was a CPA. he actually had a developmental disability. It was all physical in nature. He was in an electric wheelchair, had other physical limitations, some with limbs. But ultimately, if he experienced any cognitive changes, he would go in for an evaluation through a traditional memory clinic. He would not be the person we're talking about today, even though he has a developmental disability. We are specifically talking about those individuals with an intellectual. So good news is we're all living longer, and that includes even folks living with IDD. And when you look at specifically someone living with Down syndrome, in the early 1900s, they would have only lived to the age of 9, or the expectancy would be 9. Today, that life expectancy on average is 66 years, which is phenomenal. However, if you're living longer, you are then more at risk for the different conditions and diseases that can present later in life, and many of them can be a dementia condition. So hence our conversation today. Again, when we look specifically at Down syndrome, we see that the risk for Alzheimer's disease is even higher than the general population. And that's because the individuals born with Down syndrome have either an extra partial or full copy of chromosome 21. And chromosome 21 produces the APP gene that produces amyloid, a protein called amyloid. And amyloid is a necessary protein that you have in your brain. It has purpose and function. But once it's done, it's supposed to exit your brain through your spinal fluid, but it doesn't. It hangs out in the brain, clumps together, and creates one of the features we know about Alzheimer's disease, beta amyloid plaques. And so by the age of 40, folks living with a Down syndrome diagnosis will have plaques in their brain, along with another hallmark feature of Alzheimer's disease, the tau tangles. So we see a higher prevalence of dementia conditions for those living with Down syndrome. This diagram kind of shows you that elevated risk, or the elevated prevalence of dementia due to Alzheimer's disease with someone living with Down syndrome. So someone in their 50s with Down syndrome, about 30% of them will living with dementia with Alzheimer's disease. When you compare that to the general population, only 0.4% age 55 to 59 will actually have dementia due to Alzheimer's disease. So a substantial difference. When you look at someone living Down syndrome in their 60s, you see it's 50-50, where in the general population, it's only like 3% will have dementia due to Alzheimer's disease from the age 65 to 74. Many of these, when before the age 70, we call younger onset. So you see the prevalence is very high. And so folks that work, and family members that have individuals with Down syndrome often look at this and start to kind of question anytime there's any changes going on with anybody, if they actually are living with Alzheimer's disease. And I did a training with Dr. Pritchett, who was a psychologist. He was highly trained in doing the cognitive evaluation, not only for the general population, but also for specifically folks with IDD, and particularly people with Down syndrome. And so he got quite a few referrals and did quite a bit of his work in his career on working with this population. He received a referral, and that individual was a woman who was in her 60s, and she was referred in by the staff that in the home she lived. And they referred her in because she was, first of all, her communication skills were limited in terms of expressing herself. She had very limited to no verbal skills, but she could understand very well. So they found out that she started to decline, to not wanting to get out of bed, not wanting to get out of the chair. She refused to go to the kitchen for meals. She no longer wanted to participate in personal cares, didn't want to get dressed, didn't want to shower, didn't want to bathe. So she really was saying, I'm out of any of this. So he asked the staff to have her be seen first by the primary care provider. When you look at cognitive changes, you always start with primary care. So he referred the woman to the primary care. Well, it turns out the primary care provider discovered she actually fractured her hip. She had a broken hip. And her lack of participation into all these activities is that she was in substantial pain. And so she wasn't participating. So they did address her fractured hip. And then a period of time later, Dr. Pritchett did see her. Indeed, she did not have dementia due to Alzheimer's disease. All of her behavior and lack of participation was the result of the hip fracture. Now, years passed, and he saw her again for reevaluation. At that time, unfortunately, she did develop dementia due to Alzheimer's disease, but not years earlier during that first referral. And so he often talked in our trainings about diagnostic forecasting, that people just anticipate it would be and not think about other solutions and resolve other problems that could very much be the issue at hand. So diagnosing dementia, I'm going to tell you, if I was sitting in an elevator, the quick speech of what you need to have in order to be diagnosed. The first criteria is you have to have a measurable decline in your cognitive abilities. Your different domains in your brain, one or more, have to have sustained some changes, and they have to be from a higher level, obviously. The second criteria is those cognitive changes are significant enough that it's impacting your ability to do everyday life, impacting your function. Somehow your everyday life, whether it's cooking, driving, doing your checkbook, managing your schedule, showing up for appointments, somehow your life has been impacted by these cognitive changes that have occurred in your brain. So those are the first two criteria. The third is those changes that you're experiencing are not due to a medical or psychiatric reason. Again, you always start with the primary care, rule out any medical conditions. So a person cannot be in a coma or a psychotic break and be diagnosed with dementia. Those have to resolve before you can do the workup. So this, in a nutshell, are the three criteria that you have to meet in order to get a diagnosis of dementia. So when you look at the IDD population dementia, there are some real challenges in identifying dementia. The first problem is that often this population have medical conditions that can mimic dementia. They could have sleep apnea. If you actually address sleep apnea, a lot of times if there's cognitive changes, it reverses. There's hyperthyroidism. Prevalence is very high with the Down syndrome population, with being at 50%. So again, this population tends to have conditions that can cause impact on cognition. However, if you treat it, they do dissipate. The second is that someone with IDD tends to express dementia differently. You see the expression of the dementia through personality and behavior changes. And this becomes kind of the focus of trying to ascertain if someone does have a cognitive change going on that meets the level of dementia. This is kind of where you focus in terms of personality and behavior changes. And why is that? Because of the last two challenges. The third challenge, which is a really big one, and probably one of the most important reasons why it's so hard to diagnose, is that the person's premorbid cognitive deficits restrict them or eliminate the use of standardized tools used in typical dementia evaluation. So when you go in for an evaluation at a clinic, they have a battery test. In the memory clinics I work with, it's about a 50 to 60-minute battery. These tools that they use, an individual with intellectual disability would not be able to do. They do not have the cognitive ability to begin with, the IQ to do it. These are tools that were developed using the general population and have norms and scored that. So these are not tools that someone with IDD can actually even do. And so when you send them in for an evaluation, the tools the team was going to use, they can't use them. So that's a huge piece of the puzzle, why it's so difficult to diagnose. And the fourth reason, which is another big player in the reason why it's so difficult to diagnose, is the individual with IDD, their functional range is limited. They don't have quite the range of functionality as the general population. And so it's harder to pick up on changes in that because you're starting with less to observe a change. So let's take a look at the standardized tests that I've been talking about that's challenging, that someone living with IDD may not be able to do in the memory clinic. So these are tools, as I mentioned, so they're set up and normed. And so think about going to the doctor and you go in to have a cholesterol reading. they take your blood, they measure the cholesterol in your body, and they say, oh, if you're a man and you're an adult, this is where your level should be. If you're female, this is where your level should be. Depending how you fall will depend if they have recommendations. We have a lot of these measures in medicine. Think of blood pressure, weight, your composition, your pulse, your blood volume, your heart, your BMI. So these are all measures that when you go to your doctor, they do some type, whether it be a blood pressure cuff or blood draw, they weigh you, they measure you, and then they use your numbers and compare them to these big general norms that they have set up. This is the same for diagnosing dementia. They have these cognitive tools. You might be familiar with the MOCA, the mini mental, the clock draw, R-bands, Trail, Cognizant. Like again, there's many, many tools. And in a clinic, they have about a 50 to 60 minute battery of these type of tools that they have the person do. Most of them are paper, pencil, verbal tests. Someone with IDD are not able to do these tools at all. They also have tools for behavioral health, the geriatric depression screen, they have them for anxiety, they have them for stress. So when someone comes into clinic, the tools that the team is sitting with to use with them, they can't use. And so here's an example of them when you think of measuring the cognitive changes, you're thinking of the MOCA. And many of you may be familiar with them. And if you start looking at these tools, you'll realize why someone with IDD is not going to be able to do these tools. So this becomes a big barrier for diagnosing individuals with IDD. When I mentioned the functional part is also a challenge. So again, the second criteria, you've had decline in your brain's ability, and those cognitive declines are now impacting your function. So think about your clients. How many of them are driving a car, preparing meals, doing their financing, transportation? How many are doing all those things? And so in this population, what you'll find is that they have only a smaller range of function in these IADLs. They might be able to make their self lunch, make a sandwich and stuff, but preparing like Thanksgiving meal is not going to happen. Handling finances, investing is not going to happen. And you'll see that when we get to the tool that these are actually not even on the EDSD at all. And then when you go into ADLs, you'll see most of the clients will have capacity, quite a bit of capacity in the ADLs, and you'll see them on the tool and why they're highlighted on the tool. Now, after interviewing hundreds probably of family members that have come into clinics when I was in memory clinic and try to get history about an individual's change, there are a couple areas when someone had the early onset or the early stage of Alzheimer's disease where their function was impacted. And Alzheimer's disease has some hallmark features, the short-term memory or being amnestic. And you need your short-term memory to help you with problem solving. And so when folks came in, and if I heard that the person was having problems with their financing, their driving, and then typically they were having problems also with their medication. So these in the general population, when someone presents and you hear them having problems in these areas, that's typically a site to possible Alzheimer's disease because you need short-term memory to do those tasks. Again, someone with IDD, they don't do those tasks, so you wouldn't even get insight for them to have that change. Hopefully that makes sense. So hence the development of the EDSD. So there was it's called the D-SQUID that was developed in 2007. So this national task group took that and took it one step further and developed this tool in 2013. The tool has a manual. It's in multiple languages. It has a forum, again, multiple languages. You can get all of it, all free downloads from their website. It takes about 15 to 60 minutes. It depends how well you know the person. There are 4 primary sections, 6 pages to it. It has to be done, in my book, by someone who knows it. They recommend at least 6 months. So a family member, someone in the support system that knows the individual really well should be filling out the tool. It's an informant-based rating tool. What does that mean? It's the support system. It's their perspectives on some of these questions, and I'll point it out. It's their view, their rating of the individual. It's a screen. It provides a phenomenal visual overview and flagging system for the folks filling it out. And I'll show you that when we get to the form. It helps establishes that person baseline. As I mentioned with the cognitive tests, they're normed. So this helps set up that personal. You capture in time that what that person's skill set and abilities are on that day you fill it out. So as time goes on, if there are changes, you can reflect back to see if there has been a change. It helps your support system, if they do this, become better observers, better detectives, better understanding of the person if there's been a change. Very important aspect of the tool. It can serve as an ongoing record of health and function. It can be done annually or when cognitive changes are suspected. It is not a clinical assessment tool. It's not diagnostic. It purely is information gathering and an informant-based rating tool. It's not, has no diagnostic value at all in terms of coming up with a diagnosis. So the group recommends doing it at age 40 for those living with Down syndrome. And then for those at risk with another IDD, when you are concerned there might be cognitive changes going on. And then do it annually or thereafter, or when you suspect changes. I have a different perspective, and folks that know Jody's world, Jody often thinks a little different. My suggestion would to be actually do it for if I had a family member living with IDD, I would do this at the time they leave formal school. And there's two reasons for that. So when they leave school and go on into adult world, two reasons. One is that much of this population has gait and balance disturbance, and often a fall with a head injury can happen before someone hits 40. So you would have captured that information. The other part of this is that they're leaving formal school. The I team will have different documents I would ask for. Might be an OT, a PT, a summary, a psychologist report. I would do the tool and take those documents and put it in a folder and then wait till the person's 35 or 40. The other reason this is helpful is I often hear when I sit on webinars from other states, they don't have family care. They don't have a robust focus on vocational or centers or activities for folks with IDD after school. And so what you often hear on these webinars, that as these individuals transition out of the formal school setting, they go into homes with family with no structure, no enrichment of any type of vocational or avocational aspects. And so a lot of them take a step back or lose skill set. So by doing it at the time of transition, you actually can find out what the highest level that person is at when they're exiting the school. So that's kind of how my view is on this. If you were in a housing or day center, I would ask anybody coming new to you, I would ask support system to fill out the tool so you would have it on hand. That would be, again, my suggestion, Jody's world. So there's a manual. On page 13, 14 of the manual, there's instructions. They're very straightforward, fairly easy to see. I tend to try to print this, just the pages 13 and 14 to help me if I needed it. And then on the 15th page, you will see recommendations to a primary care provider. If there are suspect changes of cognitive changes, is what the primary care doctor might want to consider doing. And again, whenever you suspect changes, you really should start with primary care, as the case with Dr. Pritchard's patient. She had a broken hip. That was the issue. You'll see with this population, constipation, other kind of conditions that just impact their behavior and other pieces. So starting with the medical doctor is always a good way to start. Even general population, we tell them that. So this is the tool. It's 6 pages. There's 4 major sections. The cover page is fairly straightforward. Here's the excerpt from the instructions. The only thing that has changed from this from the very original is they used to put the IQ range in the mild, moderate, severe, and profound levels. They used to put them in. They eliminated that. You fill this out, fairly straightforward. Page 2 talks a little bit about their person's health, sensory pieces, any recent changes that's gone on with somebody's seizures. If you're feeling suspect of cognitive changes, a place to document that. What I recommend is that you write additional information on this form wherever you want. Again, you're taking a snapshot of time and trying to capture as much information about the person so that you can reference it at a later time. And my little figure on the left there is to remind me to point out. So when you look at question 10, general characterization of current physical health, this is that informant rating piece. So if 10 of us got together and we're going to rate an individual with IDD, and they say, okay, they have 5 chronic medical conditions, they're on meds for some of them, but they're stable. They're seeing their doctor on a regular basis. They're not having any hospitalizations. They're doing pretty good. How would you rate it? Some people would rate it excellent. Some people like, no, they have 5 chronic conditions. They can't be excellent. They're probably good or very good. So your rater on some of these items will have different opinions. And that's why it's important to kind of remember that this is based upon the rating. And when you go to have people fill it out, having the same person filling it out again might be helpful because then you can pick up on a change. So 11's the same and 12. So there are some parts of this. Again, this is a rater, observer, often opinion comes on this. Page 3 now taps into that ADL's function. And so can the person dress themselves? And one of the things I want to cue you about families that may be upset with this form, this focuses on deficits or needs or supports. It's not about strengths or the person's abilities. And so they might have a hard time reading it, but it's set up that way for a reason. So this is where you come into that flagging system or that visual map telling you something's different. So at the top, it tells you, oh, it's always been this way. Oh, it's been this way, but it's worse. And then the third column, this is new, something different. So these 2 middle columns flags you that something has changed, and it tells you, it zones in exactly where that change has occurred. Now, for me, again, I would write in. So like on this form, it says needs help dressing, but that's all it says. Do they need help dressed because they need cueing? They need physical assist? What kind of assistance? Again, write on the form. At least I recommend writing on the form more detailed information so you have a better idea of what their skill set is. Because if they all of a sudden need more, they need more assistance dressing. Well, what is it? Is it because they need more cueing or more physical or what it is? So kind of go on there. And page 4, this now taps into memory, behavior. It actually has a section for the person themselves to give some reporting, and then observation in terms of personality potential changes. Page 5 is more focused on medical conditions, probably easier to pull out of a medical record. Hopefully family would have a good sense of this, especially if they're a power of attorney for healthcare or guardian and those pieces. And again, at the top, on this page, column 1 is your red flag. This is a recent condition. This is something newer. The 6th page is kind of more of an ending where it says, okay, they're on these medications. What are they being treated? Comments, what are we going to do next? Who's filled out the form? Have they filled out the form before? So it's an overall kind of ending and putting in anything additional information that you'd want to have down. So some big red flags that the group recommends that you pay attention to specifically: unexpected memory problems, getting lost or misdirected, problems with gait or walking, new seizures, confusion in unfamiliar situations, changes in personality. And so I'm now going to turn it over to, okay, I'm just reading the chat. I missed it. Sorry. Okay. Did you not see something? Okay. I'm going to turn it over to Amy now for the next few slides.
All right. So the next slide is about So why we screen? So at community care, like Jody said, community care has done a really great job of like embedding in our onboarding and our training of new employees how to utilize this screen. So why we use it at community care? Gosh, I think we started back, if I'm not mistaken, it was probably back in like 2017, we started piloting it in several of the counties, and then we just incorporated into our typical onboarding of new employees. So why we screen is really to help members and their families plan for the future. I think Jody talked a little bit about that. And it's really to kind of capture that, if that early detection, if we can catch that early, we can also include that member with the possible dementia or neurocognitive disorder, get them involved in that planning process. So it allows them that opportunity, if they're still capable of making some of that planning and decision-making process, to get them at the table to help move forward with that. Some of that would include like decisions regarding their care and treatment, place of residence, end of decision, life decisions, any advanced directives, so that they can kind of prepare and get those things in place. And then the who and how. So like I said, at community care, both, so community care is like the care teams, the care management teams are organized, and I'm not sure everybody on the call, if you're familiar with how some of those, function within the managed care organization. So at community care, in majority of the programs, so in that actual family care program that Jody mentioned earlier, they're composed of both a care manager and then they have a nurse care manager on those teams. Community care also runs partnership and PACE programs. So those actually have different staff members, but the majority of the members that we're looking at have usually that case manager and that nurse case manager on those teams. So the care teams work with the family members. They could work with guardians. We're working with residential providers if a member is possibly in placement. So we're working with those folks to get those screens completed and then provided back to the care teams so that they can assist with that review of that screen. Once we review it, sometimes behavioral health within community care, the care teams might route that information through to behavioral health if they have some questions about it. And then the behavioral health specialist can help review that and then help make that determination if it's going to warrant that referral to primary care, like Jody said. That we function the same way. So that would be our first referral would go to primary care. And then they can also help rule out some, it might be something medical going on with that member. So primary care can help screen some of that information out. All right, and then some of the challenges. So at community care, the care teams probably have, we've seen some really great results. We've seen some folks that have Down syndrome that we've been able to do some early detection just with those simple changes using this tool to screen that member. When the provider agency has noticed some of those changes up front. So at that point, the care teams would kind of come in and have that provider utilize that tool to screen that member. And then with the information provided on that tool, we've seen, the follow-up go to primary care, and the outcome has, possibly been a diagnosis of dementia, but then we can start that early planning process. So not only does it help for that early detection, but then it also helps for how some of our care teams function. It helps support that member in whatever environment that they're living in. So they might be living in a residential facility, and that information can really help support that member. We might develop like a support plan to help the staff members work with that particular person. And also kind of going back to the beginning, it can help with that, planning for the future with that member and then their particular family members. So teams have seen some of that. At times we've seen some different feedback. So maybe we have a member that there was some concerns, and then we forwarded the care teams then charged with forwarding information to primary care. And from community care's end, what primary care gets is we usually use a form letter, and it kind of explains the NTG-EDSD, because not everybody's aware of that. Some providers are, some aren't, some are kind of getting on board with that. So it's just giving an explanation about what that NTG, the EDSD is, the purpose and the role of it within community care, and what we're trying to obtain from that, or how we can also help in trying to obtain some of that information as that care team. So sometimes we've seen that information go to primary care, and then primary care might send that form letter back. On our form letter, there's like boxes that we're hoping that primary care is willing to check, so we can kind of determine what that outcome is going to be. So sometimes we've had primary care send it back just noting that the person has a diagnosis of IDD, or maybe that member has a diagnosis of TBI. So those are some of the challenges that we've seen over the years that teams were faced with. We've probably seen a lot more of that up front. We don't see so much of it now, because I think over the years, a lot more providers have become a little bit more familiar with this process, what the NTG is, and then also how they can do some of the, like Jody said, doing some of the workups can be challenging with folks in this population because a lot of the standardized tools you just can't utilize. So yeah, we've seen some of those as some of the challenges. Some of the other challenges are when the member's living in like a residential facility. So that member might have pretty limited family. Maybe they don't even have family involved. Maybe they have a corporate guardian that's assigned to them. And when they're living in a residential facility, as we all know, there can be a lot of staff turnover. So one of the requirements or one of the recommendations for the screen is to, have somebody utilizing that tool that's known that member for at least 6 months. So sometimes that can be a little bit of a challenge, not always, but we have seen it. Or we might see a member that lives in a supportive apartment and they have, maybe they just don't have regular staff that are constantly working with them. So yeah, then our care teams step in. We try to see if we can partner up with a guardian or a person in that, member's natural supports that's known them for at least 6 months. And then typically for our care teams, there's probably either the nurse or the care manager on those teams have known that member for at least 6 months, so we can get that screening tool completed that way. Let's see, getting the form completed in its entirety. So community care had the privilege, our behavioral health team had the privilege of having Jody come last month to do a training with our behavioral health team, just doing a little bit of a refresher of the NTG-EDSD because we have some new behavioral health staff on staff. So yeah, it was actually my first time going through the tool and doing it through an example, a demonstration of using a case study and then filling out that tool. Usually I'm on the opposite end of the spectrum. So usually we're the folks that are reviewing what we get completed from a provider or a guardian or a family member. So lots of times when we get them, we've seen like there's blanks or there's missing portions, or they might just skip like a whole portion and not fill that form out in its entirety. And after it was interesting. It was actually eye-opening to me. So after going through the case study, I was actually able to see like why you might get some of that discrepancy or why you might get some of those blanks is because some of it is just given certain information. Sometimes it can be challenging to fill that out. So yeah, I think that's one of the areas that the team does see, which makes a little bit more sense. Some of the residential staff might not know that specific information and they just might not fill it out in its entirety to get it back to the care team. So then there's questions, and we just circle back to, get that tool as completed as it can be. So if it needs to go forward to the primary care, then they have as much information as they can have on there. So yeah, those are some of the challenges and benefits that we've seen from utilizing the NTG-EDSD. I don't know if there's questions about that, or Jody, if you want to do questions or finish stuff up.
Let's just do the last slide and then we'll stop the recording and address questions. I did want to mention just kind of based upon the comments with the training. So the form is ideally set up for someone who's not familiar with dementia or behavioral ID, DD. And so when we did the training with CCI, their team was all experts in behavior and all experts working with IDD. And so then like when you read the case scenario to them, in their mind, they already just reading it knew the steps to do and the differences of the different scenarios, what and what not to do. Where when you're looking at people that don't have such significant training, the form really helps guide them about understanding about what's going on. And so that's where I think it does its heaviest lift. It captures information, it makes them think about things, makes them become very good observers. So the form really has good purpose for that perspective. All right, so last slide. So overcoming the challenges in diagnosing dementia for persons living with IDD. First of all, the form helps set the person's norm. It takes a snapshot of time of the person's abilities. You really may want to consider having more than one person filling it out just because of the nature of the person's rating or viewpoint and opinions. You do the NTG annually or when there's cognitive changes. And then if I were a family member or someone, I think, again, maintaining whole records about the person, I would make sure I would have not only the NTG, but other documentation. And I say that because when folks would come into our clinic and we couldn't use all these tools, but we had an OT report that had very specific abilities of the person, we could then say, oh, can they still do this? So it helped us ascertain the changes that we're looking for. The last thing is a controversial recommendation is videotaping or auto taping the person. And it's controversial because a lot of the regulations or rules within organizations is you can't, but if you're a family member and you get permission, you can do this. And why I recommend this is especially videotaping, because after I've seen folks living with dementia and even just general population, there are some qualitative changes you see that don't actually necessarily get captured on paper and pencil. So an example is if you have someone who can make their lunch and they typically make a peanut butter and jelly sandwich, have an apple and chips, and they put it in a brown bag. You videotape them doing that. And a lot of the population you'll see very routine, and even in the general population, people do things the same way over and over again. It's just brain does it that way. So you watch them make the peanut butter and jelly sandwich. They may put peanut butter on one piece of bread and jelly on another, and then put the bread together, cut it, put it in a baggie, and then put the apple in the brown bag, and then the chips, and then the sandwich, because they don't want the sandwich to get crushed. Over time, you might discover that they're making that sandwich different. Maybe they're putting the peanut butter on one side and then the jelly on top, and or they maybe put it on the other side, don't know how to put the bread together. Maybe they don't put it in the plastic bag, they just put it in the brown bag with the apple on top. These are subtle changes that you have to pick up on. And so by having a videotape of someone doing what you think is probably their highest skill level or some skills that it takes them to do, you start to see qualitative some changes that happen. Yes, they got their lunch done, but it's not historically the way they did it. So that's just my recommendation, but I know that's controversial with some organizations. You can and cannot do that. So with that, this is going to be the end of the recording. I thank Amy for her assistance and expertise in it. I'm going to end it, and then we can address questions and comments in the chat and open up for discussion.